Good evening, dear professors and doctors. I'm Marina Nazmy, Assistant Lecturer of Internal Medicine and Rheumatology, Cairo University. It's my honor today to present the yellow clue. Dua Farouk, 43-year-old female patient, married with 3 young adults with no special habits of medical importance. Complaint: progressive jaundice for 1 month's duration. Known case of Evans syndrome for 13 years was diagnosed with systemic lupus in 2024. She has been maintained on oral corticosteroids, hydroxychloroquine, and mycophenolate mofetil that was stopped 3 weeks prior to admission to our department. In December 2025, she presented with a 1 month duration of progressive jaundice associated with dark-colored urine, pale clay-colored stools, and pruritus, with no associated fever, vomiting, abdominal pain, or distension, and no recent drug intake apart from her regular medications. Over the same period, she also developed petechiae, ecchymosis, and vaginal bleeding associated with exertional dyspnea and easy fatigability. Positive findings on examination: jaundice, xanthelasma, pallor, ecchymotic patches, itching marks, no hepatosplenomegaly or palpable lymph nodes. Investigations: CBC showed microcytic hypochromic anemia, hemoglobin was 8 grams per deciliter, iron deficiency anemia, transferrin saturation 11%, diet Coombs was negative, marked thrombocytopenia 12,000, ongoing hematologic autoimmune activity, coagulation profile was within normal. liver profile alkaline phosphatase 1108 وده كان 10.6 folds upper limit of normal. gamma GGT كان 1030 وده كان 16 folds upper of limit normal. ALT 338 وده كان 6 folds. AST 200 ده كان 5.7 folds. direct hyperbilirubinemia total bilirubin 11 direct bilirubin 8.5 وده بيشو كده cholestatic and hepatocellular pattern. Viral hepatitis markers are all negative. Autoimmune profile: ANA positive 1/640, IgM positive, anti-smooth muscle antibody positive, liver kidney microsomal antibody negative, IgG 1047 وده كان strong clue for primary biliary cirrhosis autoimmune hepatitis overlap. Lipid profile: cholesterol 629, triglycerides 235. Pelvic abdominal ultrasound: bright hepatomegaly, no CBD or intrahepatic biliary radicals dilatation, no extrahepatic bile duct obstruction وده can be favor intrahepatic cholestasis. MRCP: no signs of biliary obstruction, hepatomegaly, mildly enlarged porta hepatis and portocaval lymph nodes, gallbladder mud. Hospital course: patient received pulse methylprednisolone 1 gram for 3 days, then continued on oral prednisone and hydroxychloroquine. Ursodeoxycholic acid 15 mg per kg per day was added after exclusion of extrahepatic bile duct obstruction. After gradual improvement of platelets count, liver biopsy was taken and revealed picture of primary biliary cholangitis with bridging fibrosis. The portal tracts are densely infiltrated by chronic inflammatory cells, a few polymorphonuclear leukocytes, and show florid duct lesions. The presence of focal rosetting of hepatocytes, focal lobular inflammation, and mild interface activity suggests a probable overlap with autoimmune hepatitis. According to Paris criteria autoimmune hepatitis primary biliary cirrhosis overlap احنا كان عندنا 3 من الفيتشرز بتاعت البرايمري biliary cirrhosis. الالكالين فوسفاتيز كان عندنا 6 فولدز والجاما جي تي 16 فولدز والاي ام اي كان بوزيتيف وبلس كمان الهيستولوجي بتاعت الفلوريد داكت ليجن. وكان عندنا الفيتشر من الاوتومين هيباتايتس كلاب وايز الاي ال تي كان 6 فولدز الابر ليميت اوف نورمال in addition to histology interface hepatitis. Rosuvastatin ezetimibe was started after cardiology consultation. She received first dose of rituximab for refractory thrombocytopenia. 3 weeks later, azathioprine was added to her treatment regimen. Her follow-up labs 3 months later showed hemoglobin 12, platelets 130, bilirubin total 2.17, direct 0.76, ALT 240, AST 130, alkaline phosphatase 590. Thank you.